welcome Dr. Jonathan Pearce. Jonathan, you have 15 minutes exactly to do your presentation.
Thank you so much, Farah. I'm just going to share my slides here, and then people can see. And start that. Well, good morning, everyone from Vancouver. Thanks so much, Mathuran, for getting us started. I was asked just to give a little bit of an overview of what palliative care is, because I realize many people come from different backgrounds and may have had different experiences with palliative care and the end-of-life experience. So we'll spend a few moments talking about that, going over some of the origins of the movement and then ultimately medical discipline as it's evolved over the last decades, how the different models of palliative care have changed as we've thought about what it can be and how it can be involved in patients' lives. Thinking a little bit about the centrality of communication in what we're doing and caring for patients and understanding who they are and how we help look after them. And then just introducing some of the common symptoms that we encounter to be managed, and then some of the practicalities at the end about where does palliative care happen. And I'll try to be speaking more in general terms. A lot of what we're talking about can be applied in various parts of the world, but obviously how this actually looks in different settings and countries can be quite different. So really the roots of palliative care really emerged in the 1950s and 60s in England with such a dear woman who was essentially an interdisciplinary team unto herself. She was a physician, a social worker, and a nurse, Cecily Saunders, and she was very passionate about helping people to maintain their dignity and die, with pain control and just having impeccable assessment of their symptoms. So she had this very moving quote that you matter because you are you, and you matter to the end of your life, and we will do all we can not only to help you die peacefully, but also to help you live until you die. And so that really does motivate a lot of what happens in palliative care. And from that, so she started the initial hospice in London, St. Christopher's Hospice, and she was working with one of her colleagues in Montreal, and he was also starting some work in Canada. But the World Health Organization has certainly developed a framework around palliative care as well, and its importance around the world. The definition of palliative care from the WHO is that it's an approach that improves the quality of life of patients and their families facing the problem associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. And they really do recognize, this is just data from their website in the last month, that there's a growing need internationally for palliative care services, with estimated 40 million people in need of palliative care, and more than 3/4 of those living in low and middle income countries. And worldwide, the access to palliative care is still quite limited, with only about 14% of people who need it able to receive it. And there's a lot of reasons for that. Some of it's related to difficulties accessing medications. Some of it's related to government policies and programs, and a lot of it's related, I think, to awareness as well, and growing education around how we can improve the lives of people with advanced illness. In terms of thinking of some of the models of palliative care and how it's evolved, we used to really think of it as kind of an on and off switch, where we really treated patients, often the field started in the oncology field, so patients with cancer really treated very aggressively with chemotherapy or whatever the treatment was for the particular malignancy, and then when they no longer were benefiting from treatment, they would switch over to more palliative intent treatment, and it was a bit black and white. then gradually the understanding came in that there can be kind of a gradual increase in the palliative intent of the treatments that we're doing, recognizing that the cancer may not be curable, but that we can help a person live, as well and as long as possible, and then care continuing through until death, and then also supporting the family in bereavement. But the more modern concept of palliative care is evolving as our understanding and treatments for disease is evolving, that we can be involved very early on in the support of several diseases. This is a slide taken from the BC Cancer Agency, but can be utilized for other disease processes as well. This idea of being very involved with symptom management and supportive care through the course of treatment of the illness, and then regardless of the outcome, some people with cancer are going into remission or having survivorship, but they're still left with significant symptoms, sometimes neuropathy from their chemotherapy and things like that they need support with. And then the other is more end of life and hospice care. And it's also expanding the numbers and types of illnesses that palliative care is being supportive for patients with. Initially, as I say, we were really linked with the oncology world, and this is just looking at the different trajectories of patients as they progress through illness. So the cancer trajectory, I think we're very familiar with, where patients are able to sometimes maintain their function with treatment, and then ultimately when the cancer progresses, things do decline quite quickly. The whole area of organ failure and chronic disease is vastly increasing in all parts of the world, and how we manage things like heart failure and COPD and kidney disease and liver disease, things of that nature. And it's very much punctuated by these exacerbations and returning to some level of function, but often not quite as robust as it was before. And so palliative care can really be helpful in trying to help patients navigate this roller coaster of decision making, understanding what brings meaning to their quality of life, and the types of treatments that may be helpful to maintain their quality of life as best as possible. And then the other trajectory that is also vastly increasing throughout the world is the frailty trajectory, which is much harder to predict, but also significant needs for palliative care services there. So in terms of main central tenets of palliative care, I would say there's the communication and relational piece, where we really try to understand who the patient is that we're treating, who their family is, what's important to them, and how do we start to merge those values with their medical situation and what is possible to achieve for them. And so we really try to encourage discussion about values with the patient-physician relationship, and also with friends and family together. As we all know, it's impossible to predict every future situation in medicine and in life in general, so it's important that there's people that know what your wishes would be. And it's also really important to know that the goals of patients and what they're hoping for evolves a lot with time. And so while patients may have certain goals at the very early time of their illness, it's important to help support them as their prognosis and goals change. We, depending on the part of the world you're in, you may have different terminology for what these look like, but we're often quite involved in helping patients to think about documenting these goals in clear ways through either representation agreements, powers of attorney, living wills, and things like that. And the other big piece of palliative care is obviously the symptom management side, and it's kind of too short of a time to really go into that in detail, but pain is obviously a huge thing that we think about a lot, and we spend a lot of time thinking about the physical causes of pain and the types of treatments that we might be able to employ to help people, but we really do always come back for many patients to this concept of total pain, where suffering and the pain they're experiencing is a sum of the physical, psychological, social, and spiritual experiences that they're encountering. And thinking about this really involves an effective interdisciplinary team to work together to help support the patient and family. So palliative care services, often include physician, nurses, social workers, spiritual care practitioners, and then often occupational therapists, physiotherapists, dietitians, and many others. So the team approach is just absolutely essential for caring for patients effectively. There's obviously many other types of symptoms aside from pain that I think you can imagine people would encounter, and all of these have different etiologies and treatments to think about. So there is a lot to learn and a lot to do to help people. Also important just to think about where palliative care happens. So the terminology can get a little bit confusing, and it is different in different parts of the world what different things are called. So I realize we have people from many different countries on the line, so try to keep things as clear as possible. So there's inpatient hospice care, which usually, at least in Canada, usually for people that are kind of in the last few weeks to few months of their life, often less than 3 months of life. And often the plan of that is for people to be present there until end of life. And the goal is very much on comfort and quality of life. The other thing that inpatient hospice care can provide for some patients is respite care, where they may go there for a period of weeks to at least provide the family with some additional nursing resources to have some rest from the intensity of caring for a patient with decreasing function. The other setting that palliative care is provided is on inpatient units in hospitals. So these are called palliative care units, or sometimes acute palliative care units. And this is really for patients that do require inpatient hospital care. They may need IV treatments and infusions or other spinal nerve blocks from anesthesia or things like that, and types of medications that need to be given in a monitored setting with access to other specialized services. And then there's hospital consult services. So those would be seeing patients in other areas of the hospital, maybe on the surgical ward after the surgery, or other inpatient medical patients that have various palliative care needs, and supporting the team. And then there's home care, which is a very important part of palliative care, and is really what we try to develop as much as possible around the world, and that's trying to help keep people at home and supported by their family as much as possible, and being able to do home visits to support them there. Because I think many people, as life gets closer to the end, really do want to be at home with their family, and that's certainly the environment where they can be most comfortable. And then lastly, pain management and palliative care clinics are a growing area of interest for patients that are ambulatory and able to attend clinics. So just in conclusion here, when we think about moving forward with developing palliative care programs around the world, the WHO has given us some good foundations for thinking about this. Obviously, education is an imperative piece where you have to develop capacity of healthcare workers. And drug availability is a big important piece of making sure patients have access to drugs, and particularly opioids, because that is a mainstay of pain management, particularly in cancer. And there certainly can be challenges to that in different jurisdictions. And then working on government policy to help facilitate this, and then ultimately the implementation of these services to patients and families. So many things to think about, and we'll have some time for questions, I think, maybe at the end, but that's all I have to say for now.
Excellent. Awesome presentation, Jonathan. Jonathan, I mean, volunteers his time with us every day almost, because we have a WhatsApp group, which is a functional WhatsApp group where, the doctors on the ground ask questions, and we share our thoughts and, our expertise here. And Jonathan is the go-to person in palliative care medicine. And thanks again, Jonathan, for all your volunteer hours and your help to build this Northern Palliative Care Initiative. Thank you so much.